The session is on solid organs. The first speaker will be Vikram Attaluri from Cleveland, Ohio. Utilization of laparoscopic splenectomy and analysis from National Surgical Quality Improvement Program database. Please. Do we have him?
Good morning. I'd like to thank SAGES for the opportunity to present our research concerning the utilization of laparoscopic splenectomy analysis from the National Surgical Quality Improvement Program database. In our disclosure statement, we have nothing to disclose. As far as study design, previous research comparing laparoscopic with open splenectomy has mainly been limited to single institution experience due to the relatively uncommon nature of the procedure. The NIST dataset allows us a much larger patient population sample in which to look at these two procedures. We looked at NIST data from 2005 through 2008 from the participant user file. This included about 411,000 inpatient procedures. Using these, we were able to use two CPT codes for laparoscopic and open splenectomy to identify splenectomy cases, and we were able to compare preoperative characteristics as well as intraoperative and postoperative outcomes. Our primary endpoints were 30-day mortality, 30-day morbidity, and length of stay. We're also able to stratify patients according to ICD-9 codes into 5 subgroups: malignancy, such as lymphoma, splenomegaly, and benign splenic disorders such as ITP and spherocytosis. Also, splenic lacerations, these are all iatrogenic because by definition trauma is excluded from the NIST database. And lastly, miscellaneous, those things we were unable to classify into other categories, the most common of which was other disorders of the spleen. This is some of the just the patient characteristics, the most significant preoperative differences between our two groups here. There are about 1,122 open splenectomy cases in comparison to 1,045 laparoscopic. Open splenectomy patients were more likely to be older, less likely to be female, and also had more likelihood of COPD, renal failure, ascites, and be functionally dependent on others. Also, there's a much higher incidence of emergency cases over open splenectomy. In the laparoscopic group, the platelets were more likely to be lower, 149 versus 177, and there's much higher steroid use. And this is our first graph here, looking at the breakdown of laparoscopic versus open. So laparoscopic is actually green, whereas open is the blue graph. And it's a year-by-year breakdown. And you can see there's actually no difference in the fact that open splenectomy is used more often than laparoscopic. And this is our overall endpoints, basically. Again, the same 52% open splenectomy versus 48% laparoscopic. The overall mortality was 5.3% in open versus 2.1% laparoscopic. In the multivariate analysis, this did not come out to be a significant difference. However, overall morbidity at 28.9 versus 11.7% and length of stay at 9.2 days versus 4.1 were significant. And at the bottom graph, our table, you actually see one of our multivariate analysis concerning morbidity. So you could basically see the laparoscopic surgery had an odds ratio of 0.5 chance for morbidity in comparison to open. Also, emergency surgery was associated with almost a threefold risk of morbidity. And if you look at the very bottom there, steroid use actually did not have any difference in terms of morbidity prediction. This next slide is a little bit busy, but actually tries to break down the 5 different treatment groups that we had, the diagnostic groups that we had based on the ICD-9 code. The first 3 are benign, malignant, and splenomegaly. The last 2 are iatrogenic, injury, and miscellaneous. So in iatrogenic and miscellaneous, the overwhelming majority of those cases were actually didn't open. So the analysis mainly concentrated on the first 3 groupings there. And there's no significant difference, again, with mortality between open versus laparoscopic splenectomy across these subgroups. But in morbidity, there was actually a significant difference only with benign. There's about 11% versus 30% difference in morbidity going from laparoscopic to open. And there's no significant difference in malignant or splenomegaly groups. In terms of length of stay, there's a significant difference with the shorter length of stay laparoscopically across the board with benign, malignant, and splenomegaly groups. So in terms of our discussion, one thing we kind of identified was that many more patients are still undergoing open splenectomies despite the fact that outcomes are better with laparoscopic surgery. Now, we weren't able to really identify any particular reason why this might be the case. At first, since the literature is changing year by year, we thought it could be due to the utilization like that it basically hasn't had time to change as literature was published. However, in the 4-year period that we looked at, there was no change in the utilization of laparoscopic surgery over that 4-year period. There continues to be a higher percentage of cases done open. And also, as far as the significant shorter length of stay is consistent with open versus laparoscopic, the morbidity varied according to the ICD-9 code, mainly that benign cases where the only ones are significantly associated with lower morbidity. So in conclusion, there's significantly less morbidity associated with the laparoscopic approach in benign splenic disease, and there's an across-the-board shorter length of stay. However, more research needs to be done to identify why there's underutilization of laparoscopic splenectomy, despite the fact that outcomes are better with the laparoscopic approach. Thank you.